competency of fluid and electrolyte disorders. For this purpose of this lecture, we shall be considering about the water sodium balances, the homeostasis thereof. What is the fluid requirement and calculation in a normal child? How it differs in a normal from a sick child. What is this sodium homeostasis and dysnatremia? What are the classifications, clinical features, and management? Similarly, for dyskalemia, what is the homeostasis, classification, and the clinical features? Okay, so as you guys know, the distribution, the human body is predominantly made up of water. In fact, 2/3 of it is water. As the age of the child increases, the proportion of the body constituted by water decreases. But for practical and calculation terms, we always take 60% of the body content as water. That's around 2/3. This will be common. So a multiplying factor of 0.6 is taken for all calculations around 4 for calculating the amount of water when we are calculating it from the body weight. Okay, and of this 2/3 body water, it is important to understand that of the 2/3 of the body weight, 2/3 is water, and of this 2/3, we have got 2/3 is intracellular, 1/3 is extracellular. Of this extracellular fluid, again, 1/4 is intravascular and 3/4 is interstitial. When we do a blood sampling, we are only accessing this 1/4 part. So as you can imagine, and we are taking that as a surrogate marker of what is happening here. Okay. What is also important to understand is how the electrolytes are distributed across the cellular membrane. As we know, and as you can see, that this sodium is a predominantly extracellular cation, while potassium is a predominantly intracellular cation. And this balance is maintained predominantly by these sodium potassium ATPase, which pumps out 3 sodium out and 2 potassium into the cell for every unit of ATP that is consumed. This distribution is particularly important because this gradient is what maintains the tonicity of cells, the blood pressure, osmolarity, amongst other things. And this, as you can see, that the potassium is mostly in the intracellular fluid, while the sodium is mostly in the extracellular fluid. This is important to understand because the osmolarity of the blood, which is what is responsible for this cellular structure, and if it increases, it will lead to the cellular dehydration, and if it decreases, it will lead to cellular swelling, is maintained predominantly by the serum sodium levels. As you can see this equation, 2 into sodium by glucose by 18, by blood urea nitrogen by 2.8. So in fact, the osmolarity is most importantly maintained by sodium. Fine. So whatever effect we have on the body, so the sodium homeostasis is extremely important to understand. And sodium homeostasis is not maintained on its own. It is maintained in conjunction with the water content. The homeostasis of water, it revolves around what is the input and the output. The input is predominantly by thirst, as you know. The output is predominantly by kidneys, which is responsible for 55% of the water excretion. Evaporation is another 1/3, which is the insensible losses. Then lungs are another 1/10, and the GIT is responsible for around 5% of the losses. Fine. So in the body, to regulate the amount of water loss, it is predominantly focused on the kidneys, like by the virtue of ADH hormone. So to maintain homeostasis, it is important because this critical homeostasis is what maintains the osmolarity and the sodium content. So now imagine that this water is essentially your blood, and this has got amount of this water glass is actually the amount of blood which you have, which consists of sodium and water content. If you add a lot of water in this glass, what will happen? It will appear less salty. Similarly, if I make holes in the bottom of the glass and take out the water and only sodium stays behind, again it will become more salty. If on the other hand, if I add more water into this, keeping the salt content constant, it will become less salty. So this same mechanism is what interplays in the body. And for every amount of sodium concentration it increases, remember that it contributes to the osmolarity. Because more the sodium content in the blood, more the sodium content in the intravascular space, more the osmolarity of the blood. And more the osmolarity of the blood, more it will pull out the water from the cell cells, and this cellular dehydration takes place. So going back, if you have got more sodium in, this is the same thing what we are discussing. If your sodium increases, and this results in, just bear with me, yeah, and which results in osmoreceptor activation, activation of thirst, which in turn causes the body to quench for more water, and ADH gets activated, which in turn then reduces the net sodium concentration. So remember, the water and sodium homeostasis, they occur side by side. They don't occur through various, they occur through mechanisms like angiotensins, aldosterone, ADH, thirst mechanisms, and the body tries to adjust thereafter. So one important activity is through the ADH. Bear with me. So the ADH, what happens is that if there are any changes in the osmolarity, they are detected by the osmoreceptors, which are in the OVLT and the supraoptic nucleus, and which in turn control the thirst and the vasopressin release. These are extremely sensitive. For as little as 1 to 2% of the tonicity difference, it detects and causes a secretion of ADH. And so the osmotic threshold for ADH secretion is between 280 to 290. And ADH is the primary physiological determinant of the free water excretion by the expression of the B2 receptors in the DCT and the collecting ducts of the kidney. Also, if there is an increase in the intravascular volume, suppose the person takes a lot of water and he has got psychogenic polydipsia, or there is a lot of fluid which we are giving iatrogenically, then it will cause an RA distension and in turn results in secretion of atrial natriuretic peptide, causing increase in the sodium losses. Then again what will happen is the sodium comes down, the water stays back, and the net amount of sodium stays constant. Similarly, we have got the RAA. In case the perfusion abnormality is there because of low blood pressure or whatever be the stimulus, it will cause stimulation of the RAA axis, increase the aldosterone, and thereby increasing the sodium absorption. Similarly, so now we know any change in the osmolarity, any change in the blood pressure, any change in the tonicity, it affects the homeostasis of both the water and sodium, and they both work concomitantly. They cannot be evaluated explicit of each other. So now knowing that what causes the homeostasis, in case you guys have any questions, I would request you to please post them side by side. I will try to answer them as much as possible as the lecture goes on. So as a part of the competency that is expected from you guys, you are expected to know what is the, knowing that what is the fluid requirement, we have to calculate what is the fluid which we need to give a child. Suppose the patient is admitted under us. If the patient is awake, well accepting orally, then it's wonderful. Oral intake is there, no additional requirement is there. The problem comes when the patient is not accepting orally, he's NPO, that is ill per orally, at which time we need to give the patient supplemental fluids to take care of the insensible losses, to take care of the ongoing requirements. To calculate that, we need to assess whether the patient is dehydrated, whether the patient has any ongoing losses like loose stools, vomitings, or if the patient just requires a normal maintenance fluids. The normal maintenance is essentially it is the replacement of the water which is lost, the water electrolytes which are lost during basal metabolism. This can be calculated either by the basal calorie method, which is that for every 100 calories metabolized in 24 hours, we give the patient around 100 ml of water, 2 to 4 milligrams of sodium, and 2 to 3 milligrams of potassium. But as you can imagine, it is not easy to calculate. So we had holiday Sega who in their various studies in the 90s, 50s, and 60s, they gave various graphs on the basis of which they calculated what is the normal requirement of the body. This is called the 4 to 1 rule or the 150-20 rule. That is, for the first 10 kgs, we give 100 ml per kg. The second 10, that is between 10 to 20 kgs, we give 50 ml per kg, and after that, for every kg body weight, we give 20. Let us take an example. Suppose you have got a 19 kg child that has got the first 10 kgs is every 100 ml, that is 1000 ml. For the next 10 kgs, that is 50 into 9, 450. So the total daily requirements become 1450. Similarly, if you had a 25 kg child, for the first 10 kgs, that is 1 liter, 10 to 50, that is another 500 ml. Then for every 5 kgs, that is 5 into 20, 100 ml. So total requirement for a 25 kg child will become 1000 plus 500 plus 20 into 500, so 1600 ml. So like that, we can calculate what is the fluid requirements. Similarly, for an 8 kg child, it will only be 800 ml. So I hope you guys understand this. Now we know how much to give. It is important to know what has to be given. So to understand that, we should know that there are various kinds of fluids that are available. There can be colloids and crystalloids. They can, now the important thing is blood, but there are only specific indications for that. For the purpose of this lecture, we'll be only concentrating on the crystalloid parts, because these are the ones which we give in a normal maintenance fluid. Colloids can be given, especially when the patient has a lot of uh, third spacing, or the patient has got a lot of ongoing losses, but that is not a part of this lecture. We'll be focusing only on the crystalloids for this. To decide what fluid to give, we need to understand two important things. One is the requirement of dextrose. This is particularly important in patients of like neonates, severe acute malnutrition, bodies with a strain by sepsis. These require additional dextrose. Also, as you guys remember from the equation, dextrose is normally used in the calculation of the osmolarity. But this dextrose, which we are giving through IV fluids, this gets metabolized very fast in the body and gets converted into water. You guys must remember those equations which you used to study, that C12H22O11 plus oxygen becomes water plus CO2, and it results in generation of ATP. So like that, it will lead to generation of ATP, and because it's getting converted to water, it does not contribute into the tonicity of the fluid. What contributes to the tonicity is this, the amount of sodium content, because that is not getting metabolized, but it gets redistributed. So American Academy of Pediatrics, it recommends that for patients from 1 month to 18 years of age, we give only isotonic fluids. We don't give hypotonic fluids. Again, it is important to understand that when we are talking about this, we are talking about osmolality, not osmolarity. The osmolarity is the number of milliosmoles per liter of solution. Osmolality is the milliosmoles of solute in 1 kilogram of water, and that is a better reflection of the osmotic pressure. So you can see that the osmolality of the plasma and the 0.9% normal saline is almost the same. As you can appreciate here, that it is, bear with me, so it is almost the same, which is why we normally give things like DNS or normal saline, or things like ringalactate, which have got a sort of a isotonic fluids as compared to N by 2, N by 3, which will have 1/3 or half this tonicity. So what fluids to give? As we had discussed, we normally give isotonic fluids, which consists of normal saline, RL, and plasmolyte. So for this patient, we have calculated it's a 19 kg child, 100% maintenance, was requiring 1450. The type of fluid we decided was isotonic, so we calculated as DNS. Normally, we don't write a full day's order, we write only 6 hourly orders. So the fluid will be 350 ml DNS 6 hourly. Now remember, we have to also take care of potassium. So potassium, we need to add, as if the patient has got low potassium, we add 1 millicurie potassium for every 100 ml, which is what we call 1:100 KCl. So the fluid order for this child will be 350 ml DNS with 1:100 KCl 6 hourly. This is important and could be asked for you in your vivas as to what is the maintenance requirement you will have to calculate for the patient, which might come to you as an exam case. So then we go on to, so we have worked up that a patient who comes to us, the patient can be very sick, he can be in shock, at which time we might need to resuscitate him. This is an acute presentation window where the IV fluids or need to be given at a higher volume to restore adequate tissue perfusion and to prevent end organ injury. At this time, the fluids are given as boluses. Then we go on to the optimization and stabilization phase. Here, the body gradually normalizes, and then we can convert from the IV boluses to now what we do is optimize. We give deficit correction. So the boluses have been given, now the patient is dehydrated, so we give some deficit and maintenance. Then when the deficit correction is also taken care of, then we go on to stabilization. Once the patient has recovered, maybe after 3 or 4 days, all the extra fluid in the body will take care of itself and remove it through urine. That is the evacuation phase. So normally we consider when we are giving extraneous fluids, external fluids, we are talking about the resuscitation, optimization, and stabilization phases. So here is where we replace the fluids on the rate required, depending upon the deficit, maintenance, and ongoing losses. So let's talk. Now we have discussed about the maintenance fluid. Now we will discuss about the deficit correction. We have discussed that in a resuscitative phase, when the patient is in shock or the patient has got poor pulses, we will need to give additional boluses. Normally, when we give boluses, we give 10 to 20 ml per kg of isotonic fluids, normally normal saline or dingalactate. And then once the patient has re-established perfusion, then we can start by calculating what is the fluid which we are giving. We give deficit, maintenance, and ongoing losses combination. Suppose you don't give the deficit, only start with maintenance. What will happen is that you will end up playing catch up, because the patient, you are, for example, the patient has already reached a fluid level of -200. You have now started at a maintenance fluid of 50 ml. It will take you 1 day of 50 or 4 rations of 50 ml to reach the normal maintenance. You know, to reach a point of zero where you should begin with at the starting. So it is important that when we are calculating fluid, all three fluids are calculated separately and the volume started. Ideally, to calculate the deficit correction, we should have the pre-illness weight. But as you know, often the patient is coming to us for the first time and we don't have the luxury of doing that. So we calculate it as per the clinical features. I'm sure you guys know this from the IMNCI lectures. If not, I'm sure Dr. Ashima will be taking it for you. You guys are aware that on the basis of clinical assessment, on the basis of dehydration, skin turgor, buccal mucosa, sunken eyes, presence of tears, where the patient is drowsy, where the pulse volume is steady, if the urine output is appropriate or not, we can assess how much amount of deficit is required, whether 5%, 10%, 15% in the case of infant, or 3, 6, 9% in the case of older child. This you can see is an example of a delayed skin turgor. So you can see that the skin turgor in this particular patient is quite delayed. Going on, as you guys can see, this is a sunken eyes and the mucosa is also dry. So on the basis of these particular signs, I'm sure you guys must know about the IMNCI algorithms. We can assess whether the patient is in no, some, and severe dehydration and give plan A, B, or C fluid accordingly. In plan C, we end up administering the patient's additional fluids like 100 ml per kg IV, depending upon if the age, whether he is more than or less than 1 year of age. As you can see it, we can decide whether to give 30 ml per kg in 1 hour in infants and half an hour in kids more than 1 year, and then the remaining correction of either 5 hours in infants and 2.5 hours in bigger kids. And if the patient is less dehydrated, it's moderate, then we can give ORS, that is enteral dehydration, at 75 ml per kg. And if the patient has got mild or no dehydration, then we can continue ongoing care by just giving ORS for ongoing losses, zinc, and showing the patient what are the danger signs. Going on, the ongoing losses. So now we know the maintenance, now we know the deficit correction. we need to know what are the ongoing losses for the patient. The ongoing losses can be either vomitings or stools. Remember that there can be, depending upon what the fluid is. If the patient is having vomitus that is coming on from the gastric juices, it will have a lesser amount of sodium. But if the patient has got bilious vomiting, it will have a higher amount of or small bowel vomiting. That is because of distal obstructions. Then the patient will have a higher amount of sodium in the losses. This will result in the patient having going into hyponatremia if we are not replacing it adequately by fluids like ringer lactate. If only gastric, we can replace only with N by 2. But if there is a distal losses, we need to give fluids like NS, sorry, or RL to replace it. So let's take an example. We have got a 3-month-old 5 kg patient who has come to us in shock. If the patient is in shock, as we had discussed in resuscitative phase, we'll be giving a fluid bolus. So we gave a 100 ml NS to make the patient, so that is 5 kgs, 20 ml per kg. We gave a isotonic fluid bolus over 15 minutes to make sure that the patient attained a normal uh, pulses. And after that stability has achieved, we now start the dehydration correction. Now we saw this patient was severe dehydration, so we called, and obviously he was in shock, so we started plan C. 30 ml per kg, so 5 into 30 is 150 RL over 1 hour, followed by 350 over the next 5 hours. Alongside, we started maintenance, and the ongoing losses we continued with ORS. Now going on to sodium. In the as you know, it is important for regulation of fluid and electrolyte balance, tonicity, blood pressures. It is also important in maintaining the ECM volume, and it is also important of neuromuscular excitability. And to maintain a sodium homeostasis, we know that the enteral intake is most important, and it is absorbed from the distal small bowel and the colon. And the excretion is again by the it is filtered by the glomeruli freely, but it is absorbed to a significant extent by the PCT. Around 2/3 is absorbed from that. The remaining is absorbed either by the ascending limb or through the GCT and the collecting ducts. This in this particular thing, the RA plays an important part. The various other hormones like the patient the CMP, dopamine, and all those things, they also exert an antidiuretic effect. So if we have got a patient who has got let's talk about a patient who has got suppose excessive sodium. If the patient has got sodium increase, it will pull the water into the vasculature. Then, as you know, it is responsive to osmolarity. Then it will lead to the volume distension. So the RA myocytes will get activated, ANP will be released. So the atyl natriuretic peptide will be released. This will also increase sodium will negatively reinforce the RA axis, decrease the ADH, and decrease the thirst. This will in turn cause uh, increased sodium losses, and this will in turn maintain the homeostasis. The opposite thing will occur when the sodium is lost, at which time the RA axis will get activated and the sodium will get retained. So going on, the hyponatremia. As you guys know, that hyponatremia is a sodium of above 145 milliequivalents per liter. I hope you guys have understood this. Sorry, I just wanted the questions. Do you want to ask anything? How do I see this? No potassium and resuscitation phase. No. So you will not remember when you are giving boluses. So you don't want to give 20 ml per kg of high amount of potassium, because remember the potassium, whatever you give, it gets redistributed. It will not be reflected a lot in the intravascular volume. So if the patient is, and you don't want to give a huge amount of potassium load. Now imagine you are giving 20 ml per kg with 1:100 kcal, and you are so 1:100 is like and you are giving it over 15 minutes. You will end up giving a huge potassium load. The body will not be able to cope up with that, and you will have features of hyperkalemia, and ECG abnormalities will start taking place. Going on. So I hope you guys have understood this, right? Okay, bear with me. Okay. So what is important to understand is that acute hyponatremia is normally less than 48 hours and chronic is more than 48 hours, because it takes some time for the body to adjust to it. What happens is that on the first day of, why does it occur? Again, as I've explained to you guys, that it is a play of water sodium homeostasis. If the patient has got increased water, it will lead to less sodium, it will decrease the osmolarity, osmoreceptors will get activated, the body will stimulate. If the patient has more water, again the same thing will happen. So if the patient has got decrease in the amount of so depending upon how the ADH is acting, how the aldosterone is acting, we can decide as to how the body can decide on its own, depending on the osmoreceptors, as to how much amount of sodium and water needs to be retained by the various hormones. Now, why is this happening? So, as we had explained earlier, this is the same thing which we are talking about. That this is your intravascular volume. This is the sodium ions. Suppose I add more amount of sodium into it, the osmolarity will increase and osmolality will increase, and obviously those receptors will get activated. Then we'll have to add more water into it to calculate it. But and if we just remove the water from it, again the amount of sodium content in this particular intravascular volume will increase. On the base, now apply that to the total body water. This is the total glass of water, and depending upon what is the amount of water and sodium which you have, it can be classified as euvolemic, hypovolemic, and hypovolemic. I hope you guys are able to understand that. So going back, depending on how much water we are adding and how much sodium we are adding. Suppose we have got conditions in which the amount we are just decreasing the amount of water, but the patient is essentially it is recalibrating itself. It becomes slightly dehydrated, but the water was able to compensate between the ISF, ICF, and the ECF. That is the euvolemic. Suppose we dehydrate the patient more and the patient lost more water. At this time, it is hypovolemic hyponatremia. This is easy to calculate because if the patient is hypovolemic, sodium is high, you can always add more water. If the patient was euvolemic, still there is some space, I can add more water. The problem occurs is when the glass is completely full, that is it's hypervolemic, and it is also this patient has got a lot of salt. Now there is no way you can get this now the body is full of water, the body is full of salt. How do you get it out? This is a problematic part. So hypovolemic hyponatremia, this is where you need things like dialysis. So this is where the main problem occurs. So what are the various causes? Hypovolemic causes can be if the patient has got diarrhea, burns. Then euvolemic is if the patient has got a lot of sensible losses. And hypervolemic is if the patient has got either iatrogenically being administered, or the patient has a congestive heart failure or a renal failure. That is that he cannot excrete the amount of sodium and water, but we keep on giving him additional salt. So in those conditions, this happens when the patient has gone into ATN, but the mother keeps on giving the patient faulty ORS or faulty salt, faulty prepared ORS at home. And when the patient comes to us, has already gone into an ATN, that is acute tubular necrosis, so he can't take the sodium out, and the patient already has a lot of sodium being administered. At this time, we need to give the patient extracorporeal equivalent by doing dialysis. Now, it is important to know what is the impact of the sodium on the brain. So, beginning on the first day of hyponatremia, what happens is that hyponatremia means that the osmolarity is increased in the blood. So the blood will pull out the fluid from all the cells. So the volume is lost from the brain into the CSF, thereby increasing the interstitial volume, and the uptake of solutes by the cells is decreased. Then gradually what happens is there is a accumulation of the intracellular osmoles. So body starts producing osmoles like myoinositol, glutamine, glutamate. They are osmotically charged amino acids which can retain the fluid inside the cells. So we reach, by slow adaptation, the body reaches a stage where it can exist in equilibrium with the externally increased osmolarity. Now, this is a place, suppose the patient comes to us in the acute phase and we correct it rapidly, that's all right, because the brain had not adjusted. If the brain has adjusted, this is a setting of a chronic hyponatremia, and we suppose give the patient a lot of dilute fluids. What will happen? You will, yes, you will decrease the osmolarity outside the brain. So like we had discussed, in the glass of water there was a lot of salt, you put a lot of water in it, so the external extracellular fluid, your sodium content decreases, but you, that did not happen in the intracellular space where it is like raisins. So it is still very osmotically active inside, so all the fluid will go inside the cells, and like raisins it will get swollen up, and you would have features of cerebral edema, which is why it is important to correct it slowly. As when we do it slowly, all these osmotically charged um, substance like myonisole, they get there are various co-transporters, like there is a sodium inositol co-transporter, and there is activation of inositol efflux mechanisms in the cell membrane. So they actively pump out these osmotically charged substances into the ECF there, and over the next maybe 3 or 4 days, the body will adapt to the slowly correcting sodium water imbalance which is happening, and the chance of uh, edema decreases. So we know that the clinical manifestations mostly occur when the sodium is more than 158. So we remember the osmolarity was 2 into sodium. So a normal osmolarity is how much? 270 up to 285. On a sodium of 160, the osmolarity is 320. So remember, from a normal osmolarity, it is increasing by 30, which is when the patient starts having features. And life-threatening occurs at a sodium of 180, which is an osmolarity of 360. At this time, you can imagine that the brain will be squeezed out of the water. All the water will be taken out of the cells. Okay. So what happens is that so it is the osmolarity which determines if the patient has in these lesser amounts. So 350 is a sodium of around 180, isn't it? Restlessness irritability happens when the sodium crosses around 200, at which time the patient can even die. So the mortality rate is actually quite high. The patient with hyponatremia, they have got features of hypopnea, that is increased respiratory rate, muscle weakness, high pitched cry, and this, they often have a doughy feel of the skin. This unfortunately impairs the skin pinch sign which we had discussed earlier. Older kids, they might have augmentation, they might have weakness, they might have focal neurological deficit because they stroke out sometimes. And remember, in hyponatremia, seizures don't occur, but if you rapidly correct, you will have features of increased intracranial pressure, at which time due to cerebral edema, yes, you can have hyponatremia. Sorry, seizures. Then the main principles of treatment are, if it is acute hyponatremia, then yes, you can correct it fast, but the basic dictum is we correct it very slowly, not more than 10 to 12 milliequivalents per day. The method of replacement can be oral or IV. If the pulse rate is very high, we need IV correction. The type of fluid, it depends again whether it is isovolemic, hypovolemic, or hypervolemic hyponatremia, and hypotonic fluids. Remember, the hypotonic fluids have higher amount of water. So the main thing is the same. We add more water to the salt to decrease the saltiness of the blood. Fine. So except in the case of shock, and which time we need to give resuscitation fluid. So even if the patient has a sodium of 165, if the patient is in shock, you will still need to give NS, because the first priority is to take care of the shock. Going on. So in hypovolemic fluid, you can give N by 2. Euvolemic, we can give plain water, and hypervolemic, unfortunately, we often require to take out the fluid, so we may need to do dialysis. There are various equations like advocatrias which we can use to calculate the amount of sodium change. The complications of hyponatremia include CPM. So if it is treated very rapidly, rhabdomyolysis, mental retardation, epilepsy. Going on, hyponatremia, this is when the sodium is less than 135. It can be mild, moderate, or profound, depending upon whether it is 130 to 135 or less than 125. Similarly, depending upon what is the rate at which the sodium loss has taken place, it can be acute or chronic, because it gives the brain that time to adapt. The opposite thing will happen here. If we are making the patient hypotonic, the fluid will actually enter the astrocytes and it will cause a gain in the brain matter. And if you guys remember the Monro-Kelly doctrine, in which the brain plus blood plus CSF is constant, because of the increase in the blood matter, it compromises on the other things, and it has features of increased ICP. Then gradually, what happens is the patient has loss of organic osmolytes, and then it adjusts. Again, if we correct it rapidly, it will lead to osmotic demyelination. In this also, the principle remains the same. Correction is very slow, of not more than 10 to 12 milliculents per day. Remember, it is not per kg. It is 10 to 12 milliculents per day. The clinical features depending upon what is the fault. So how rapidly hyponatremia has occurred and how much hyponatremia has occurred. Whether it was an acute profound, whether it was a chronic profound, whether it was a chronic mild, it will just depend upon that. The symptoms will be features of nausea, vomiting, agitation, headache, so features of increased ICP. And as we have discussed, there can be anatomical changes again because of increase of the brain matter. And it will have all the features of ICP like headache, nausea, vomiting, and seizures. It can be classified on the basis of tonicity. As we had discussed, it can sodium again determines the amount of osmolarity. So 135 sodium corresponds to around 270 milliosmol per kg of osmolarity. If it decreases, it will lead to the other kind. So it can be hypotonic hyponatremia. These are conditions like SIADH, heart failure, because the body is retaining more amount of water in this. Then it can be hypertonic. This is when there are extraneous salts like hyperglycemia. Remember the equation 2 into sodium plus glucose by 18 plus BUN by 2.8. So if this glucose is very high, the body compensates by decreasing the amount of sodium in it, which is why when we need to calculate for diabetic ketoacidosis, we need to calculate the corrected sodium values. Okay, and then there can be obviously a pseudo hyponatremia. Are there any questions you guys want to ask? Can you explain the fluid resuscitation? I will come to that after the lecture is over, because I think there are some part which needs to be covered. Okay, going back. So hyponatremia, it can be either hypovolemic, euvolemic, and hypovolemic, as we had discussed. Hypovolemic is when there is sodium and water both is getting lost. This it can be because of renal losses, diuretics, salt losing, nephritics, osmotic iotics, like we are giving the patient a lot of furosemide, or there can be extrarenal losses like in case of burns. It can be euvolemic like in SIDH, and hypovolemic, that is the patient already has an excess of fluid, be it nephrotic, be it cardiac failure, be it acute liver failure, and then we are ending up and this patient has got less amount of sodium. So how do we manage this patient? First of all, we need to find out whether it is a true hyponatremia or not, because as in conditions like diabetic mellitus, this patient can have either just a readjustment of the electrolytes across the cell membrane because of the increase in the extravascular osmolarity. Similarly, in conditions like hyperproteinemia and hyperlipidemia, it can be falsely low. So the management principle remains the same. It will be management. You will not increase the sodium more than 10 to 12 milliosmoles every 24 hourly, or in other words, not more than 0.5 millimoles per hour, which is why the importance is of frequent monitoring. Irrespective of what fluid you start, you should monitor this patient every 3 to 4 hourly for the first 24 to 48 hours, because that is what will determine how far, whether the patient is getting an adequate amount of loss of sodium as we want or not. Then it is also important to know why this has occurred, because if the patient has got ongoing losses and the patient has got deficit, those will need to be replenished as well. Let's not discuss about osmotic demyelination. We'll talk about potassium now. So potassium, as we know, it's an electrolyte which is there in the intercellular fluids. It is again responsible for maintenance of a skeletal and smooth muscle contraction, and it is also an important part of the ATP metabolism. It is there predominantly in the intracellular space. So whatever amount of potassium you give, it will be rapidly redistributed and it will go inside the cells. Of the amount of potassium that needs to be lost, the predominantly kidney is what is responsible for the excretion of potassium, and the colon is responsible for a minimal part of it. So imagine that we are giving 100 milliequivalents. Predominantly, it will get redistributed to the interstitial fluids, and only 2% will get in the extracellular fluids. Here we have got, if we have got various drugs, which like insulin, alkalosis, all these can drive it more inside the cells, and things like acidosis, if the patient is in shock and has got acidosis because of lactic acidosis, or if the patient has got rhabdomyolysis or any such, or tumoritis, any such feature which can get the potassium out of the cells into the extracellular fluids. So depend, what is important is, if this potassium comes here from outside the interstitial to the extracellular space, that is when it starts having these symptoms, because it disturbs the sodium potassium gradients and it disturbs the normal cardiac contractility. It results in various kinds of arrhythmias. So in that case, you guys should know what are the causes. I will be discussing both hypo and hyperkalemia together for the lab of time, which I think is already 250. So in the dyskalemia, when it's hyperkalemia, again remember, for any electrolytes, either there can be an increased intake, either there can be a reduced output. That is the most important thing. So for sodium, either you take more or you excrete more. But in potassium, there is an additional thing. It can get redistributed also. So it can be more intake, it can be less output, or it can be less redistribution. So in case of hyperkalemia, either we are giving iatrogenically high potassium, like somebody was saying, if you give a high amount of potassium in resistive phase, it will not get redistributed. It will just cause all the features of hypokalemia, ECG, abnormalities imminently, and the patient might even die. If the patient has got reduced losses, as you know, the kidney is responsible for 90% of the potassium losses. So conditions like end-stage renal failure, administration of drugs like ACE inhibitors, which are, all those things can cause hyperkalemia. Then anything which is driving the potassium out of the cells. So things like acidosis, things like there are other features like there is an interaction between the magnesium and potassium through ROMK channels. So if you are, that is, magnesium helps potassium to act. So in conditions like hypermagnesemia, it can result in manifestations of hyperkalemia. Similarly, for hypokalemia, if this decreased intake, this is more common in severe acute malnutrition, or if there is increased losses, like if the patient has vomiting, sweating, if the patient has looped the diuretics, or this has got increased redistribution. If the patient is alkalotic, if you administer the patient insulin, these are the strategies which we use normally when we have got a patient of hypokalemia with us. So how do we detect that the patient has a symptomatic hypokalemia? One of the first manifestations which we have is, and what is what we are more scared of, is essentially what is happening to the heart. So in a normal kalemia, you guys are well aware of the morphology of electrocardiogram. In hypokalemia, gradually what happens is the conduction abnormalities. You have got slight, you have got prolonged peer intervals, you have got shallow T waves, ST depression, you have got peak P waves. While in hyperkalemia, what will happen is that there will be decreased R wave amplitude, there will be flattening of P waves, the peer interval get prolonged. Normally, features of prolonged QRS, the various arrhythmias, DF, all those start happening there. So we need to investigate why hypokalemia is happening. This can be, again, as you know, if we see whether there is a kidney abnormality, because kidney is the responsible for 90% of potassium excretion. If the kidney abnormality is there, again, either it is increased, so decreased excretion, so things like ARF, CRF, or increased intakes. Either there is hemolysis, there is rhabdomyolysis, there is iatrogenic hyperkalemia. If the patient has got normal kidney functions, then either it can be that the patient has got RAS activation because of various things like RTAs, which will cause excessive amount of bicarb, excessive amount of excretion, and can manifest with hypokalemia. Or if the patient has, if it is aldosterone is low, at which time we need to see on the basis of renin levels, that whether seeing where the patient, if the renin is high, it can be conditions like primary hyperaldosteronism, or if the hyporeninemic is there, states are there, then it can be things like diabetic nephropathy or interstitial nephritis. So if you have got a patient of hyperkalemia, the first and foremost thing is to stabilize the membrane. We give calcium gluconate. This is to stabilize the cardiac myocytes, and this acts immediately. But its duration of action is very small because it's just counteracting the potassium at the level of the cells. Then we need to act on the other things. Now there are two ways where you can take the potassium off. You can either push it into the cells, but when you push it into the cells, remember the total body potassium remains constant because you're not taking it out. If you want to take it out, then you need either extracorporeal means or to give certain drugs. So for pushing it into the cells, we can use insulin dextrose infusion. This acts, this is quite effective. We can do a salbutamol nebulization, or we can alkalinize the blood by administering sodium bicarbonate. All three pushes the potassium into the cells. Similarly, if we have to excrete, we need to give drugs like furosemide. This again is only important if the patient is stable. If the patient is having low volume to begin with, or the patient is in shock, you can't give it. At which point you would need to give potassium sequestering resins, which can be either given per orally or per rectally, and sodium polystyrene, and they enhance the GI excretion. Remember, this is not very easy to give because when mixing with water, this becomes quite thick and viscid. Then finally, there can be extracorporeal removal, which can be through either a CRRT or dialysis. Going on to hypokalemia, this is when it is less than 3.5. It can be either when there is a pseudo-hypokalemia, when you have not taken an adequate sample. Remember, when we're taking samples through a central line or a line where already IV fluids were taken, and without taking account of the dead space, when we just take out the blood, it will get diluted with the IV fluids. So you might have a false low or false high amount of sodium and potassium. So it is important to take out the dead space of the central lines before we take out a sample for either for electrolyte estimation. Then, as we had discussed, reduced intakes, magnesium through the because it acts synergistically with potassium on the ROMK channels. They can be redistributive by either alkalinization or metabolic alkalosis, and which will cause in hypokalemia. Again, how to diagnose hypokalemia? We know that the most common losses can be either through the kidneys or the what do you call it, the GI. So from the GI, if there is loose stools, so if you have got the increased losses not from the kidney, so urine potassium by creatinine ratio is less than 1.5. So you know it is extrarenal losses, which is mostly from the GI. So if you have got diarrhea, if it is renal losses, it will depend upon how the patient is. If the patient is maintaining blood pressure, or the blood pressure is high, which means that the RAS is activated, then there can be various conditions like renal artery stenosis or Cushing's, which can cause it. If the blood pressure is low, then it will depend upon whether the patient has low plasma bicarbonate, then conditions like RTA, or if the patient has got high bicarbonate concentration, then again we will need to estimate the urinary chloride. If the gastric losses are, if the urinary chloride is less, it means that it is extrarenal. That is gastric losses which are there. If the urinary chloride is more, it means the conditions like Bartter, Gittelman's are causing it. So how do you manage hypokalemia? Ideally, if it is mild to moderate, we can give, especially when it's mild, we would ideally give it through dietary supplements. There can be various things like oranges, bananas, which we can give. And Then if it's moderate, we can still consider oral supplementation. Remember, the most common preparation available is pot chlor, which has got 20 milliequivalents per 15 ml or 1.33 milliequivalents per ml. So depending upon how much losses are there, we can give 2 to 3 milliequivalent per kg per day through enteral route. Remaining we can give through IV route also. But remember the same problems which were discussed earlier. When we give IV, it has to be given very slowly under very strict monitoring, and it has to be given when we are giving it IV, it needs to be given under ECG cardiac monitoring. So it needs to be, and through one route. So if it should not be that at the same time you're giving orally IV through PD fluid, because then suppose the patient goes into hypokalemia, you will not know what to stop. So it is ideally when we are correcting hypokalemia, especially through IV route, it should be given through one route, say intravenous. Then this is, I'm talking about severe hypokalemia, and then we calculate how much is the deficit, and then we give a slow correction. We don't give a very high amount of fluid. So remember, if we have got less than 2.5, we can give 0.5 to 0.75 milliequivalent per kg, but we need to give it over 2 to 3 hours under strict monitoring. Also, this KCL is causes a lot of tissue irritation. So it is important that either a whiteboard cannula or ideally through a central line this has to be given, because if it gets extravasated, it can lead to tissue necrosis also. So it should ideally be given through a central line. Going back, we should add, if we are giving things like furosemide, adding spironolactone, it might help in because that's a potassium sparing diuretics. It will help in conserving the potassium value. Then we need, because magnesium and potassium act as synergistically, we need to, in cases of refractory hypokalemia, we need to exclude hypomagnesemia as a cause. Okay. So now I think time is over, but I can still take a few questions. Where do I go? How do I see the questions? Yeah. Okay. Now tell me. Hello. And Elaine, now you can ask me, what questions do you guys want to ask? Can you guys hear me? Am I mute? I'm not mute. Yeah. Okay. So what are the questions? Let's start from the top. So no potassium correction in resuscitation phase. I hope you guys understood that. Rose concept. So Rose concept is not very important for you. This is just a mnemonic which says resuscitation, optimization, stabilization, evacuation. So you have got a resuscitative phase in which you are giving the patient. So this is a patient who has come to you. The patient is in shock. The patient is in was in severe dehydration. The mother didn't notice, and the patient kept on having cholera stools and became even more dehydrated, so much so that it compromised the what do you call it, the balance between the blood flow required by the for tissue perfusion, which is the classic definition of shock, isn't it? So at which time our first priority is not to give maintenance, it is to correct and make sure there is enough volume in the body to, so that it can maintain tissue perfusion. At this time, the importance is of giving fluid boluses. Normally, we give fluid boluses at 10 to 20 ml per kg, and when we are giving boluses, we keep on assessing for hepatomegaly, we keep on assessing of presence of rales, we keep on assessing of features of fluid overload. And then when we have corrected that and we now have good peripheral pulses, at this time we have an optimization phase. So when we are optimizing, then we are giving the, remember, all three things. So maintenance, what do you call it? Maintenance, your dehydration correction, and your ongoing losses, depending upon what is the cause. Suppose he's got excessive MSS, if he's got excessive cholera stools, and then you have to calculate accordingly. Then why there is all, yeah, so there is altered skin pinch and hyponatremia. This is because of the increase. So you know what happens in hyponatremia, your osmolarity is actually high. So your blood it has got high amount of water. It has got high amount of um, water in it. So unlike, so when you, it's like having a raisin which is full, which was, you have you can imagine, when it, the raisin has got a lot of osmosis inside it. So similarly, when you the vasculature has got a lot of osmosis inside it, when you try to squeeze the water out of it, it will not squeeze out. So it will still retain its texture because it has got, so which is why the skin which has got a lot of sodium content will still retain the texture of itself. It will not have the altered skin pinch, which we call, quote unquote. That is that in like in hyponatremia or some, or in isonatremia, because the there's a cellular dehydration. As we pull it, there's a, as we pull the skin, there is less amount of fluid, less in the interstitial space, and so it goes back very slowly. While in hyponatremia, it's the other way around, because the osmolarity is high, it keeps the fluid inside, so it will go back very slow. Okay, can you explain the fluid in three varieties? Oh, that's a big question. So which will actually take time. So I can try to explain you one. Bear with me. Let's see if I can just bear with me and try to see if I have got an example for you guys. Okay, so I will explain to you with one example. And you guys see the screen now? I really can't know whether you can see or not. And you guys see the screen now? Okay, fine. So here you can see, let's talk about this. So if you have got a patient of sodium abnormalities, we need to make sure. So if you have got hypernatremia, so in this what happens is we need to correct two things. We need to correct free water deficit as well as solute deficit. What is important is that the rate of production has to be optimized. So let's start with the free water deficit. We know that either you can calculate it from the zero 0.6 into weight into this thing, or there is another equation which you have got, total body water, which is zero 0.6 into body weight, right, into what is the body sodium by what is the normal sodium, that's 140 minus 1. This is one way we can calculate, or we can just calculate as 4 into weight into sodium excess. So if a patient has got 10% dehydration on the basis of the clinical assessment and the serum sodium is say 156, so fluid correction for 10% dehydration is 10 into 10, that's 1000. So free water deficit will be 10 into 0.66, right? Because the body water is 0.6 into the weight into 156 by 140 minus 1. So that is 686 ml. Then we need the, what is the water deficit? So water deficit. So then what is this? What do you call it? Solute deficit. So this much is the total fluid. The deficit is the water deficit. The isotonic loss or the solute deficit is essentially a difference between the two. So that's 314. So to replace the patient, we will need again the three things. We will need to correct the deficit, that is the dehydration at 686 ml. We will need to correct the isotonic loss that is happening. We need to replace the ongoing losses. So maintenance, you guys know already, for a 10 kg child is 1000 ml, and the normal requirement of sodium is 3 milligrammes per kg. So that is 3 into 10 is 30. Normal requirement of potassium is 2 milligram per kg, so 2 into 10 is 20. We know the deficit of water is 686. We know the isotonic deficit or the solute deficit is 314. Fine, and this needs amount of sodium, and this needs amount of potassium which needs to be administered. So how do we calculate? We add the three up. So we add the total maintenance, we add the total fluid, the maintenance, free water deficit, and the solute deficit, and we get a total amount. So we get a 1800 ml. Then we add what is the sodium which we need to give. So suppose you need to give 67 milliequivalent in this much amount. Now, if you guys remember that if the patient in a normal what do you call it, 0.154. So in a normal saline, we have got 154 milliequivalents in 1000 ml. So in every ml, it is 0.154. So for 67 milliequivalents, it will be 67 into 0.154 or 66.9. 67 ml is required of the 435. So that is around n by 4 that is required. Another method is, which is the easier method, which health and pediatrics gives, is you give 1.5 times maintenance as n by 2. But again, the importance is of 3 hourly sodium connection. I think my time is up, so I will need to go off. If you guys need to ask me, you can ask me later. Like, where's my questions? Yeah. Okay. Fine. So yeah, you guys can ask me anytime. I've got no issues with that. Okay. Fine. So I think I will just turn it off because the next person must be waiting. Thank you guys.